Good afternoon, doctors. I am Dr. Prashant, welcoming you on this webinar on experience sharing program with Carbetocin, sponsored by Hydro Healthcare. As you all know, Hydro has got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio with presence in 126 plus countries, 21,000 employees globally, and amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hydro Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hydro Healthcare pioneers in quality and innovation and has distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic area, Hydro Healthcare, the pioneer in antivirals, brought oseltamivir, favipiravir, and remdesivir for patient care, for which they received an award for the contribution. Today's session is we have got Dr. Girija Wagh with us to share her experience. Welcome, madam. Dr. Girija Wagh is VP Foxy. Madam is Professor HOD, Head of Department of Obstetrics and Gynecology, Bharatiya Vidyapeeth Medical College Hospital, Pune. Senior Consultant, Cloud9 and Apollo Hospital, Pune. Faculty Professor, OGASH, International Expert General Coordinator 2016. Madam is Chairman, Medical Disorders and Pregnancy Committee of Foxy. Vice President, India Chapter, Gestosis. Member Governing Council, ICOG, 2011 to 14. Joint National Secretary, Foxy. Assistant Coordinator, National Eclampsia Registry since 2008. Member of Central Supervisory Board of PCP NDT Act 2010 to 2014, National Mentor Laksha NPOCQCN, Ministry of Health and Family Welfare, Government of India, and a recipient of Anandibai Award, Anandibai Joshi Award for Excellence in Medical Services. Once again, welcome, madam, to this seminar. And
Thank you. Thank you for the nice introduction. And currently, I must tell you that I am no more. I was the Vice President of Foxy last year.
Okay.
And I've done with that responsibility. But also, thank you for reminding me about that.
Yes.
So it's going to be a wonderful session. And we all know that postpartum hemorrhage, though we have been able to make some strides with the help of companies like Hetero Health, which have come up with Carbetocin and things like that, it's very important to constantly be abreast about what's happening on this front. And that's what we are going to do in this session and try to make it as possible, as interactive, as well as based on practical experiences. So most importantly, can you just have the next slide, please? Yeah. We all know that it is a daunting event, and many times it's spoken in terms of the amount that is lost. But there's a very simple definition which is very important, that the moment the clinician feels that the blood loss is more, you must immediately start acting. Now, there is a rider here. When they went and tried to assess this particular dictum, trying to analyze whether the visual assessment was right or wrong, it was found that many a times there was a wrong assessment of the amount of blood loss. But then the dictum goes that the moment you feel it is not as usual, you must immediately start acting. And therefore has come the role of prophylactic medications, oxytocics, which can be used to prevent this particular malady, because we have had some of our senior colleagues telling us that we never had these problems, but today we are seeing older women are getting pregnant. Adenomyotic uteruses is a reality. Secondly, atonicity happens even because of anemia. And conditions like preeclampsia, where the mother is already having less blood volume, even if little blood volume and blood loss will typically make her immediately exsanguinate. Plus, many times the birthing positions in our country happen to be in a lithotomy position, and therefore the assessment of the hemodynamic arrangements may not be quickly available. So the simple things are, therefore, is being said that rather than looking at the amount of blood loss, it is important that you look at the hemodynamics with which the patient is presenting. Because if a patient has 500 ml blood loss and she is a preeclampsia patient, she'll already get into shock. Even with a 350 ml blood loss, it is going to be more for her. And therefore, today we are looking at how best and how quickly, and best is uniform and universal universal application of prophylactic medications, irrespective of the fact whether the woman is at risk, because so many times it's been found that despite there being no risk factors, the women have had experienced postpartum hemorrhage. Can I have the next slide, please? So, as we see that, it's very important to know because it continues to be the leading cause, and you are seeing that these are the recent references of maternal mortality accounting for 35% of the deaths, and especially in developing countries. If you look at the MMR, which still continues to be 240, it is important that we pay heed to this particular action. And globally, when we look at the incidence, 14 million women suffer from PPH, incidence being 2.4% after vaginal birth and 6% after C-sections. And in India, nearly 38% of maternal deaths are due to postpartum hemorrhage. Nearly 26% would take place in India, and two-thirds of these attribute to PPH. And India has an unexpectedly higher maternal mortality rate. It is improvising thanks to all of us who are working together, trying to bring about modernization, change, checklisting, and definitely I'm sure that one day we will be able to deal with it. The maternal death rate, which has been mentioned here as 540, is a little more, not that's not the one which is currently. We have come down drastically. Thank you. Next slide, please. Just a moment. Now, why is there postpartum hemorrhage? The commonest reason found is the tone. And we are always, and this is something which is very easily applicable even in our clinical practices, always we should be on the track of the tone. Now, on the track of the four T's. And one of them, the commonest one is tone, where the uterus doesn't contract adequately. And as I mentioned to you, adenomyotic uteruses, overstretched uteruses, especially when there has been a long-term usage of blood thinners like low-dose aspirin or heparin, or if there has been a use of progesterone therapy, which has been used quite commonly nowadays, you will find that these uteruses undergo, possibility of increased atonicity. Coagulopathies are there. Many times they go unrecognized, but anemic patients, preeclampsia, hypertensive disorders, patients who have been taking blood thinners are all at risk of developing this kind of a contribution. And what happens in pregnancy being a thrombogenic condition, there is a constant one factor, and that is the tissue factor issue, which is there. Larger placental tissue factors will continuously keep on coming in the mother's circulation, initiating and quickly activating the coagulation failure pathways, and therefore we have to be aware of this. Trauma, especially the commonest iatrogenic trauma that we give to the mother is a cesarean section birth, and these are the ones which have to be looked for. There can be an extension while we are doing it. At the time of vaginal birth, there can be trauma. Use of oxytocics irrationally have also led to traumatic postpartum hemorrhages. And then large babies, especially when now we are having quite a few women having diabetes. In these women, they would have high hypotonicity as well as a risk of trauma. And then tissue is another factor where the placental membranes or bits may remain inside. Placenta may not separate. And nowadays, with the rise in the ART pregnancies, for some reason, we are seeing a lot of rampant issues where the placenta doesn't get separated quickly. And plus, we have rising rates of morbidly adherent placenta, which are responsible for these postpartum hemorrhages. Next slide, please. So whenever we look at the clinical findings, as I mentioned at the outset, you would find that the first thing that the obstetrician should be looking at is the pulse rate of the woman. And there's a very simple index, and which is called as the index of 1, where if the systolic blood pressure is below 100 and the pulse rate is 100 or more, be on guard. Probably this patient is bleeding and is now going to get quickly into problems because during pregnancy, hemodilution, increase in the blood volume, award some sort of a protection and compensation against blood loss. And despite losing 10 to 15%, or sometimes even 15 to 25% of the blood volume, the woman will not show any hemodynamic instability. But if she loses 25% or more, you will appreciate that there is hypotension and tachycardia. And this is the time where you must act. Maybe, as I told you, the index of one, or you can say using the obstetric shock index and quickly trying to find out whether she requires any kind of resuscitation. Because typically after that, you would see patient getting restless, pale, becoming pale, oliguric, and then that would be a moderate blood loss, about 25 to 35%. And if there is a hypotension which is considerable, then usually patients will quickly get into irreversible shock and DIC sequencing. And therefore, one has to be looking at maternal tachycardia, uterine tonicity, and then any clues that probably she's bleeding inside very, very diligently. Next slide, please. So initial evaluation would be rapid assessment of the status, tachycardia and hypertension, assessment of vital signs and blood loss, especially women who are hypertensive. We may get completely off the guard because they've been taking those beta blockers for a long period of time. Then they would first show a reactionary hypertension and we may not understand them. There could be a concealed bleeding in the form of abruption and we may not be able to assess them correctly. Assessment of the genital tract is very important, looking for lacerations, any extension of tear, any kind of vaginal lacerations. It's extremely important. And additionally, one can take care of POCUS, which is point of care ultrasound by the bedside to see if there are internal hematomas or any kind of dehiscence on the uterus, which will be able to give us more idea. I have had an experience of using imaging in a patient who was referred to us with recurrent vaginal hematoma and been explored at least thrice outside by an obstetrician. I quickly first ordered a CT angio and we found that it was actually a laceration of the pudendal artery. Quickly, we did a unilateral internal iliac ligation and solved the problems. So one can consider using imaging to evaluate and correctly diagnose a proper history assessment, and most important, giving respect to the persons or the people who are sending the patients to you, because they are obstetricians and experts who have done it and still they have failed. That means we have to look at it from a different angle. And then laboratory helps us in trying to analyze as to which level of anemia it is, how much are the platelet counts, and what are her coagulation parameters. Next slide, please. Now, whenever we have a patient presenting with PPH, it is always better to have mental algorithms, and sometimes you may tend to get into panic. It's always better to have such kind of displays there, which will help you and guide you quickly to take action in case of a poor uterine tone, to use the uterotonics in the proper dose, and this can help you even in the personnel who are assisting you, using oxytocin, prostaglandins, ergot and the right time in the right places because they may be not indicated. Uterine balloon tamponade, I'm an absolutely proponent of it because we have saved so many lives with uterine balloon tamponade when used diligently. The NHG garment, that is non pneumatic anti-shock garments, which can help keep the blood supply to the mother's brain and prevent such kind of problem. Quick assessment of bleeding from the traumatic places. And nowadays, many places have access for doing angiography, and you can also do embolization of the internal iliac arteries and take care of the trauma. And then, of course, retained tissues have to be analyzed properly. And sometimes nowadays, we find that even with a good advent of antibiotics and monitoring, we can consider sometimes keeping the placenta inside under close surveillance. And of course, coagulopathy has to be quickly addressed by using tranexamic acid prophylactically or giving factor 5-7 or various kinds of blood components. So it's very important to identify what is the cause and what's going to be your next action so that we can effectively take care of postpartum hemorrhage. Next slide, please. And now, therefore, we have something which is very, very effective, and this is carbetocin. Now, what is so great about this particular carbetocin? It is a heat stable formulation because that was our big concern. Because many times our regular oxytocin may not work if it has not been kept in a proper cold chain. Herein, you don't require to do it so. Plus, it has all the safety of oxytocin. Additionally, it has an advantage of a long term action and an immediate action. And therefore, it would definitely not give make it necessary to use another oxytocin. And especially in women who have hypertensive disorders, we are concerned giving methylargometrin. Prostaglandin, even if it is effective, not only is it expensive, but sometimes it is not recommended for prophylaxis, it is always for therapy. So the prophylactic armamentarium that we have is oxytocin, methylargometrin, misoprostol tablets, or carbetocin. And today, carbetocin has been found to be beneficial because of its stability at room temperature, longer shelf life, doesn't need cold chain and logistics, and it is also present in the form of a vial. Next slide, please. So when do you administer? Usually prophylactic, which is typically called as AMCEL or active management of third stage of labor, when the baby's head is delivering. So at the delivery of the baby's head, typically after the anterior shoulder, that's so that you know that the shoulder dystocia has been ruled out. And then it's also important to be sure that there is no second baby sitting inside. At the end of the second stage of labor, also intramuscularly it can be given, or it can also be considered giving after the delivery of placenta. It's always a good practice to give it at the delivery of the anterior shoulder. So by the time the baby delivers, your uterus starts acting. And thus, it is used prevention of PPH and active management of third stage of labor. And management of postpartum hemorrhage, we have to consider using oxytocin, ergometrin, sintometrin is not available in our country, and misoprostol. But I have used an intravenous sintometrin formulation in dilution for patients who presented with severe thrombocytopenia and dengue and with abruption. So you have to keep on trying to use your combinations correctly so that you are able to save lives. Next slide, please. So what is carbetocin and how does it compare to oxytocin? It has created by making several modifications to the oxytocin structure so that it would help in reducing the enzymatic degradation and prolong the half-life. It is synthetic long-acting analog of oxytocin, and it is especially important for prevention of atopic postpartum hemorrhage. And one vial would contain 100 mcg of carbetocin in 1 ml solution for injection. Next slide, please. And what are the clinical evidences? So most important is the champion study. And this WHO champion trial, even our country has contributed many cases to this trial. So it's not a trial which has been thrown to us from the Western world. Many of our women also participated as subjects in this particular trial. And this has been a non-inferiority double-blind randomized trial where the objective was to compare the effectiveness of safety of investigational heat stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. 30,000 women across 10 countries, including ours, participated. And the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents was studied, and proportion of women with blood loss of at least 1000 ml also were factored. Next slide, please. So when we looked at these parameters, it was found that carbetocin had similar efficacy as oxytocin, and especially the frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin, and the use of additional uterotonic agents. Interventions to stop bleeding and adverse effects did not differ significantly between the two groups. So the conclusion of this study was it was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional eutotonic agents. Next slide, please. So the Cochrane review then came about talking about carbetocin for preventing PPH. And it was a review data from 11 studies involving approximately 2.635 women. And it concluded that women who undergo cesarean birth, carbetocin resulted in statistically significant reduction in the need for therapeutic eutotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Next slide, please. So let's look at the guidelines and the recommendations. And these are from the various societies, as we can see, the SOGC, the Danish Society, the MOH of Russian Federation, expert group of Polish gynecological societies, Mexican, Philippines, Queensland, and Chinese Society of Obstetrics and Gynecology. So what did the WHO write in its guidelines for PPH prophylaxis? First line of drug oxytocin, second carbetocin, then misoprostol, then ergometrin, and then the symptometrin combination. SOGC Canada says carbetocin 100 micrograms IV bolus. Ranzoxy New Zealand says AMTSL prophylactic eutotonics have to be used. FIGO says carbetocin is one of the recommendations for PPH management. Now, this is something that FIGO has pushed in. Germany, Austria, and Swiss body says 100 micrograms slowly IV carbetocin can be used. And FCOG, that is France, say carbetocin on providing non-inferiority to oxytocin achieved by the CHAMPION trial. Next slide, please. So now let's look at certain experiences that we have encountered in our practices. Now let's see carbetocin in normal vaginal birth. This is Mrs. Asha, age 28, gravida 2 para 1. No known comorbidities, had full-term spontaneous vaginal birth. And the intervention which was used was 100 micrograms of IV carbetocin post-delivery for prevention of PPH, which is a universal protocol which we use in our center. So we either use oxytocin or we either use carbetocin. And we have also done a randomized study between these two molecules, and we have found the same results as the CHAMPION trial. And the observations here were that it definitely reduces blood loss compared to prior oxytocin use. There is no need for additional eutotonics, stable vitals, and no adverse drug reactions. And therefore, carbetocin as a single dose would offer a long-acting alternative to oxytocin in low-risk vaginal births, because we know oxytocin has a shorter half-life, and therefore you have to keep on monitoring this patient while you will be awarded a lot of confidence when you're using carbetocin. Next slide, please. Now, this is our second case wherein Mrs. Fatima, age 32, gravida 3 para 2, underwent an elective cesarean section for her previous cesarean section history. And as the dictum goes here, 100 micrograms of IV carbetocin was given post-delivery, enhanced uterine contraction and PPH prevention. And what was found was there was definitely less intraoperative blood loss, no additional eutotonics were necessary. There was faster recovery and reduced monitoring was essential. And therefore, the takeaway for this practice was carbetocin is more effective than oxytocin in cesarean deliveries with better hemodynamic stability. Next slide, please. So carbetocin in high-risk pregnancy, this is case study 3, where Mrs. Neha, gravida 4 para 3, who had a history of PPH and is anemic, was scheduled for C-section. Now, we all know that she has risk factors. One is she is multipara. She has a history of postpartum hemorrhage. Usually, history of postpartum hemorrhage awards nearly 45% risk of postpartum hemorrhage in the concurrent pregnancy. And the significant reduction, so she was given carbetocin during C-section as prophylaxis, and there was a significant reduction in blood loss, less hemoglobin drop, no transfusion or additional eutotonics needed, And we all know that methyl argometrin would not be very safe in women who are anemic, and therefore it's always better to use a safer alternative. And we found carbetocin is one, highly effective in high-risk pregnancy, reducing complications and improving the outcomes. Next slide, please. So in summary, where do we place carbetocin? It's a very, very important component of our armamentarium to save lives, which may get exsanguinated, or women who may be morbid because of postpartum hemorrhage. It's effective in reducing blood loss in normal and cesarean births. Single dose administration is enough and improves patient comfort. Better hemodynamic stability compared to oxytocin. Highly effective in high risk pregnancies. And therefore, one can consider using this as a first line agent for PPH prevention, and it's important that we follow the WHO guidelines and clinical protocols for administration.
Thank you so much, madam, for sharing your case studies. I'm sure the audience must have benefited out of experience. But interesting thing I knew is that in anemia, methyl argometrin is to be avoided. And it's very interesting. I was not aware of that.
See, what happens is chronic anemic patients, they are at risk of heart failure because there is sudden
Okay.
rise in the kidney.
Yeah. And in my time, I mean, we had only two drugs, oxytocin and methyl argometrin.
And then we used to only switch कि जो
Exactly.
patient at risk है उसको intramuscular ले दो, जो risk पे नहीं है उसको IV दे दो.
I we did though. Always praying and hoping that the PPH is a good topic to discuss, but a very bad one should never get it. So,
Absolutely.
I mean, you have already shared your experiences, Kar. But generally use IV or IM also you have used.
Carbetocin?
Yes.
I'm working in a tertiary care center and all my practice
Okay.
is in the corporate. So we give IVs.
IV, yes, correct. And patients where we can expect at PPH, of course, expect the unexpected, but generally speaking.
Classically, patients like obesity is one,
Okay.
but even thin patients, very thin ones, because they have very less blood volume. Thoda bhi ho gaya, so they will go into
Correct.
postpartum hemorrhage. Like when women who have some comorbidities, like if they are hypertensive, diabetic, adenomyotic uterus, because it doesn't squeeze adequately.
Contract, yeah.
And then obesity, the dosages may be necessary. Patients who have been in prolonged labor for a longer period of time, large babies, that is what we are experiencing
That's
nowadays. But even if you have a small baby, then why the baby is small? Maybe there was some placental reason why she's having so. Women who have been taking blood thinners, as I mentioned while I was talking, anemia,
yes.
even 10-gram hemoglobin is increases the risk of postpartum hemorrhage,
Okay.
because we should have a zero acceptance for anemia, and the definition of anemia during pregnancy is less than 11 gram percent. So if
Okay.
the patient is presenting to labor, you have to ensure that her hemoglobin is always 11 or more, because if her hemoglobin is 10 or less, chances of she going into PPH are extremely high. And cesarean births, then any kind of instrumental deliveries, and retained placentas,
Yeah.
morbidly adherent placenta, or any kind of placental abnormalities. These are all the typical ones which will cause PPH, and we have to be on guard.
Yes. And especially patients, I mean, there may be some elderly, not exactly elderly, but patients on aspirin can also be common.
Yeah, low dose
Yeah,
aspirin and
yes.
LMWH and progesterone are very commonly used, and that is the reason why they.
Another thing. Yeah.
Yeah.
When would you prefer carbetocin, actually speaking, or oxytocin thing, even
It can be a
before?
universal one taken, with as a prophylaxis.
So first line drug like.
Hmm. It can
Can
be
you
also. Because we have done, as I told you, head on head, and we found it quite comparable.
can you use carbetocin in case of your experience, retained placenta?
So retained placentas are, is now not as easy as it used to be in the
Okay.
past. Because first and foremost, if the placenta is retained, we are first we'll do an imaging as well. We'll give utrotonics like carbetocin or oxytocin. And we will want to do a sonography, because we must look at the placental residual interface, because sometimes placenta may be abnormally adherent.
Oh,
But if you have to do an MRP, it's always better to take her inside the operation theater, give some
absolutely.
anesthesia, and then try and attempt to remove the placenta. We have landed up in keeping partial placentas even at C-sections, as I told you.
Baapre. Oh,
ART cases, especially the ones which present with PROMs, it's just impossible to take away that placenta. And then we really land up in big soups. And
yeah.
we are managing, and we are really, there are certain patients who do present, and they are typically associated with ART pregnancies somehow. IVF pregnancies, placental
Yeah.
separation is a problem.
In Rh negative mothers,
We can use, there shouldn't be
okay.
any problem, because nowadays we are giving antenatal also
Yes, yes, yes.
IPD prophylactically, isn't it? The only thing is, it's always better to be careful, like not to unnecessarily squeeze the placenta and do
That is right.
fishing. Many times that placenta is just pulled out. All these things we should not do. We must allow the uterus to nicely squeeze, give it a massage, then take the placenta out. All these things are to be practiced.
Less interference will always help in proper
Hmm.
management.
Hmm.
Okay, can a doctor use carbetocin for prevention of PPH if oxytocin was used for labor induction?
Pardon?
If oxytocin was used for labor induction, can a
Huh.
doctor use carbetocin for prevention of PPH?
Yes.
Yeah, there shouldn't be a problem because they both act on the same receptors.
Hmm. Yeah.
I mean, you prefer IV always. If a
Hmm.
patient is not responding adequately with carbetocin, what
Hmm.
would be the next? What is your preference in order of preference? Your choice in order of preference. Next, uterotonic,
It's prostaglandin, always.
prostaglandins. Advantage of oxytocin, misoprostol, and carboprostol.
And if
Overall,
the methyl argometrin can be considered if the patient is non-hypertensive and anemic and heart
yeah.
disease. These are the three contraindications. So
And
the
I suppose,
advantages of carbetocin are basically long acting. It is
uh,
long acting because and carbetocin is definitely a little safer than carboprost and methyl argometrin.
yeah, 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 yeah. And madam, what about ADH side effects with oxytocin? How common have you seen those side effects?
I haven't seen, unless and until it has been used in a very high dose,
Uh,
there can be a delayed complication like water retention.
correct.
I haven't seen any.
I mean, you have clearly said that it should be a first-line drug. There's no question of this.
Yeah.
Even adverse effect profile, have you seen adverse effect with carbetocin? Any adverse effects in your practice?
No. I have seen one that was little hypotension, but
Okay.
I feel that must be related to the concurrent action of sensorcaine, which is given for
Uh-huh.
anesthesia. Maybe it must have peaked at the same time as the
Okay, okay,
carbamazepine
okay.
action must have peaked. But that was ones which I had experienced.
Just a takeaway message for the audience
Mm.
about carbetocin. What do
So
you
you
feel?
should have a proper and adequate preload or a co-load before doing a C-section, so that such a thing cannot be, will not be encountered.
Thanks so much, madam. Thank you so much for your insights. I'm sure people have benefited. Thank you so much for your time.
Thanks,
Yes,
Atan.
thank you. And thank all the field personnel of ITRO, marketing team of ITRO for conceptualizing and doing this, coordinating. Thanks all the audience for attending. And thanks IT team for your IT support. Thanks all of you. And wish you a very pleasant afternoon. Thank you, madam. We can
Thank
sign
you
off.
so much. Thanks,
Thank you.
Atan. Thank you.
Thank you, ma'am.
Hello.
Giridhar, we can sign off?
Yeah.
Yeah, we can sign off, madam.
Yes, ma'am.